Computer. Welcome, everybody. I just want to welcome you all and all of our listeners to this podcast, to the Healthcare Supply Chain Hub. And this is where we do our every Tuesday 30-minute learning bites about hot healthcare supply chain topics. I am Angelique Beslick. So glad to see you all. Thank you for those of you that come live. I love it. Thank you for everyone who listens to the recording replay later. That's also super duper cool. So good to see everybody. And let's jump in to our topic this week. All right. I really want to talk today about the value-based care model and how supply chain literally is the missing link in value-based care and the total cost of ownership model. This is really a hot topic for me because I actually am starting to teach everyone that value analysis should be absorbed into your clinical operational service line model at your health system. And I'm going to kind of go through a little bit of why here in this podcast, but also if you guys take my certification program, you'll get a ton of that why. And if you guys want to reach out to me to really just say, Angelique, I'm going to pressure test you. Why are you doing that? I would love the discussion. Okay, so let's kind of get into this energy for today. Value-based care, I believe, fails not clinically, but operationally. And the supply chain is at the center of that. When I think about total cost of ownership of a supply, equipment, a device, and root causing why patient outcomes are why they are, what percentage of patient outcomes issues are because of the equipment, the technology, the device, the supply versus because of clinical practice? And I mean, some would argue to say, well, there a lot of times whatever was used was not trained or educated and it wasn't used correctly. Thus, then we had an issue, with patient outcomes. That happens, right? But then there are times where just clinical practice itself, maybe we weren't taking a clinical pathway the correct way, and we didn't admit someone fast enough, or we did not, look at length of stay, and we didn't do something correct during that clinical pathway. That happens as well. But I want to really just nail into why supply chain operationally is at the center of a patient outcomes or reimbursement issue, for example, or where I am seeing supply chain, a lot of us chasing the price at the pump, at the contract on the front end, and we are not concentrating at all about the total cost of ownership and the back end of care or of that supply or of that device or of that piece of equipment. And, how is that affecting our value-based care model? All right, so let's kind of jump in to just value-based healthcare and why it matters. So today we are feeling it, and even January 1st, we're going to feel it more with all of the changes that are coming with the one big beautiful bill, right? Margin pressures, revenue pressures, right? Quality expectations, workforce shortages. I don't know about you guys, we just went through a RIF. I hear a lot of people are going through RIFs out there. Variation, not just in our formulary for supplies, pharmaceuticals, devices, but also variation in our clinical practice. And we also are looking at CFO and all C-suite visibility right now over supply chain. And today's leaders must connect supply chain to outcomes. How many times am I hearing people building a value analysis program and they're touting that it's all about the quadruple aim? And in the end, the only thing that mattered or made the vote was still just the cost of something. Right. So we have to be focusing on the outcomes, quality measures, safety, satisfaction, all those other things that come along with that quadruple aim. We cannot just be focusing on the cost. And that's actually where fee for service goes away and value-based care model comes into play. All right. So some key takeaways today. Value-based care is a supply chain problem, but we are not the process owners of it. Right now, I'm working with my current team on a new clinical operational service line model where supply chain is just a problem owner of that. If you guys know lean operating system, you know the difference between problem owner and process owner. Supply chain is just a problem owner of that. We don't own the process of our clinical operational service lines, but we are definitely a problem of that, right? Just like IT and IS is a problem of that. Population health is a problem of that. There's many different supporting functions of that. Total cost of ownership, TCO, equals the outcome, our patient outcomes, right? And that's going to be driving our MIPS scores and our reimbursement models, and things are going to start to, reimbursement is going to start to decrease. We're going to start to see penalties up to 9% on reimbursement based on readmissions, right? So the point is governance matters. Having a governance structure, not just over your supplies and services decision making, but absorbing that into clinical operational service lines and having governance over that I'm solving for an outcomes issue, but I'm bringing supply chain in to solve for that and having governance around that decision-making process. And really blueprinting, some kind of blueprint, a system, a process solves those structural gaps. And that's kind of really what we want to talk about today. There's a lot to absorb today, so I'm going to talk pretty fast, but this one is really, really good. So the gap that no one talks about. Hospitals say they're moving to value-based care, but like I just said earlier with value analysis, we said we were moving to quadruple aim, but I'm still seeing a humongous percentage of our decision-making based on cost. And we're still bringing to the value analysis committee meetings the financial impact statement. But where are you tying in all the outcomes data? Supply chain still operates like a fee for service. And this mismatch really is a silent margin loss. If supply chain only has access to spend and utilization data, how in the world are we driving value-based care when we can't get access to the data we need for patient outcomes, right? So that's really where this gap is. Well, supply chain can't have access to that. Why would they have access to that? What do they need access to that data for, right? There's a lot of those conversations happening at a system level. So the big truth is every product decision impacts, right? Length of stay, readmissions, complications, workflow, OR time, documentation, safety, reimbursement, total cost of ownership, total cost of care. All the outcomes, quality, safety, and supply chain tracks price, conversions, terms, but we don't have our hands on all this. Throughput, turnover times, all these things. We don't have the opportunity to have our hands in that. But why? Why is that? Why, health system leaders, are you not focusing on this? Why wouldn't your second largest spend in your health system be one of the most important things you are putting onto your strategic priorities every year, and trying to figure out how you bring them into the fold of value-based care? So where value-based care breaks down, if you think about it, product variation, which because you have product variation, you're driving clinical practice variation, siloed clinical value analysis, decisions happening in this silo where you think it's where the conversation should happen, but it's not in the conversation where outcomes decisions are being made, which is in your clinical operational service line structure. Reactive sourcing, right? We're just trying to keep up with renewing contracts like crazy people. No total cost of ownership because you don't have the data for it. We don't get our hands on it. Weak governance. You may have governance over supplies and services decision making, but it doesn't tie to what the service lines are driving. We have preference card chaos. I'm sure all of you are shaking your heads right now going, yes, that is a huge issue. All these operational workflow issues causing chaos and fragmented data. We were just talking the other day where I'm at about just every different team asking for data and modeling of data, but no one's coming together to say this is all of our data and this is how we model it all together to make one decision. Supply chain's asking for this data. Population health is asking for this data. IT is asking for this data. Everyone's asking for their own data. Physicians are asking for this data. Service line leadership is asking for this data, but no one is marrying it all together, right? So if you think about the fee for service mindset, the old way, what's the price, right, of a product? What's the price? Price at the pump. Everyone cares about chasing another dollar off. Give me another dollar off, supplier. That's all that I care about. Is it on a contract, right? We want to make sure everything's on contract. Of course, that's procure to pay. But everyone is chasing the next conversion because they're chasing price. And does that have anything to do with patient outcomes? And that literally is 2008 thinking. I'm going to say it's way before 2008 thinking, but it is. If you think about value-based mindset, the new way, how does this impact the patient outcome? How does it impact length of stay, variation cost, my reimbursement, right, of the case, total cost of ownership over time? And when I even think of total cost of ownership, I'm even thinking about waste on the back end. The price at the pump is no longer even a part of, it's only a little part of the conversation. It is no longer the total conversation, right? So thinking about total cost of ownership, that is equal to our outcomes model, not the PO price. And how are you guys calculating that today in your health systems? It has to include everything all the way to consumption, reimbursement, waste on the back end, environmental sustainability, DEIA, all those things that are part of how your health system operates. It's clinical, it's operational, it's financial, it's standardization, not just of formulary, but of clinical practice. It is vendor impact. It's your relationships strategically with your vendors. It is implementing 100% at the bedside so you don't have contractual scope creep. All these things are part of your total cost of ownership. So I'm thinking about some examples of where total cost of ownership fails. Okay, so just some examples. You've got some cheap implant, you got the best price, and you chose the cheapest one. It could actually lead to more OR time. More OR time actually affects your reimbursement. You think that an insurance company is going to look at you, you have more OR time on this cheap implant. This guy over here that's got a little bit more quality, more expensive implant has less OR time. You think that they're going to reimburse for more OR time? No, absolutely not. If you think of, here's another example, a cheaper catheter. I bought the cheapest one. I feel great. I got $5 off of it. But what if it leads to a failure? It broke, or the connector didn't fit, or there's something wrong. Well, now I have to throw 6 of them away just to get one that's going to work, right? Think about dressings. Wound care is probably supply chain's, arch nemesis, right? Because we're constantly being sold on a cheap dressing, a cheap something for wound care. That actually will equate to skin injuries or more infections right? Or, and when we think about infection prevention and control, think about skin injuries. Just choosing the cheapest dressing, I got the best deal, price at the pump. We can no longer be looking at it that way. Trialing creates variation as well. You just start bringing in a whole bunch of things for your clinical teams to trial and evaluate. Now you're confusing the heck out of the clinicians, right? Well, I don't know. I tried this one for 30 days and I tried this one for 2 weeks and I tried this one for 2 weeks and now I'm really super confused. And where is the evidence? And then if you think about poor vendor fill rate, oh, I converted to the cheapest thing, but now they can't fill their orders because all that the vendor did or the manufacturer did was concentrate on pumping the cheap stuff into the market, and now they cannot deliver. There's no supply assurance. So just think about these different examples where total cost of ownership actually fails because it creates more cost for you somewhere else within the pipeline of ownership. It's not just you contracting and buying it. It's all the way to consumption and reimbursement. In that entire pipeline, there's tons of room for failure, right? And that drives the cost up, or it drives your reimbursement down, which drives your revenue down. So you can lose money in way more ways than buying the cheapest thing on the front end. And I got savings. Yay, I'm supply chain. I got savings. So at some point in time, I'm looking for supply chain to stop actually reporting savings in contract savings. I'm looking for total cost of ownership savings all the way to reimbursement. I can't wait for those days to come because they're coming. Governance is a real problem. Clinical value analysis cannot fix value-based care alone, especially if your value analysis committees are working in silos, right? Service lines cannot fix alone value-based care as well, right? Clinical operational service lines that have governance and are well-oiled machines can help fix value-based care, along with value analysis principles. And if you absorb value analysis into your clinical operational service lines, even better. That's what I'm pushing. But finance cannot fix that alone. We know from savings, contract savings, right? Finance can't just fix that alone. Supply chain cannot fix that alone. It has to be a well-oiled machine and governance. And I'm talking about a strategic priority at your C-suite level saying we are going to do value-based care. And this is what it means to us. And it is a huge team of people. Yes, supply chain sits on the team, finance sits on the team, the service line leaders, administrative and physicians sit on the team, population health sits on the team, IS and IT sit on the team. All of these groups, care management sits on the team. CMO sits on the team, CNO sits on the team, hospital presidents sit on the team, operations sits on the team. Absolutely, but it's everyone driving it for your health system. That is governance. The next time somebody tells me that it is supply chain's responsibility for the second largest spend in the health system, I'm literally going to just probably say I need to quit health care because people aren't getting it. They're not getting it. You can see how passionate I am about it. So when you think about clinical value analysis inside of your clinical operational service lines, that's COSL, okay? Physicians won't vote outside their specialty today. So if I have a perioperative CVA committee meeting and I have someone from GI, endo, general surgery, trauma surgery, neurosurgery, ortho, I have all these physicians, great, they're all sitting on the committee. But the trauma surgeon comes and they present something. Yes, a physician says, well, the clinical evidence looks like it's there, but it's not my specialty. I don't feel comfortable voting on it. So what are they looking at? The financials. Oh, the financials make sense. I'll vote yes. Even though they know in their mind the clinical proof and evidence makes sense, but I don't feel comfortable or empowered to vote outside of my specialty. That is happening today. If you moved value analysis into clinical operational service lines, that would be the whole service line looking at it and being able to vote for it inside of their specialty. Because service lines actually own their outcomes and supply chain controls just levers, right? Just the contract. And do you want me to bring a vendor in? Do you want us to hold a vendor accountable? Should we create performance metrics for a vendor? We control all those levers, but actually the service line owns those outcomes and those decisions. And value-based care requires shared accountability. That's why clinical value analysis makes sense inside of clinical operational service lines. It just makes sense because other decisions are already being made on behalf of the service lines. It makes sense. They're making decisions on where care is going to happen, inpatient, outpatient, where in your region, where within the states your health system operates. They're making decisions around how, hey, are we going to hire and do some recruiting and onboarding of new physicians? They're making those decisions. Well, then they should also make decisions on, hey, what's going to be our robotic strategy for our service line? Hey, what's going to be our if they're cardiovascular, what's going to be our vascular stent decision across all of our service line at all of our sites? It makes the most sense, right? They're dealing with outcomes issues, length of stay, readmissions. They're root causing some of these issues. And then they find out the root cause is the equipment or the device. Well, it just makes natural sense for value analysis to be in that room, right? And with that team. All right. So if I think about supply chain as the strategic lever, right? Aligned supply chain improves length of stay, readmissions, variation, workflow, reimbursement, margin, safety, because we're there as a lever. Pull on us when you found out that the root cause of an outcome of a patient or of a workflow mishap or of a safety issue was supply chain. Pull on us as the lever. We're a strategic lever. Let us sit at the table. Don't just point a finger and be like, that's all supply chain. That's supply chain's fault. Oh, the supply chain did it. Well, the supply chain needs to figure it out. No, we need to be part of the accountability conversation, especially in value-based care. All right. This actually requires a leadership shift. This is actually a cultural change within your organization. This has to come from the C-suite. This has to be an adopted methodology to drive value-based care. It starts with the outcome, right? Patient outcomes is where it starts. You have to build a governance. You have to have a structure. You need to inventory all of your service lines and make sure you've got all of them represented. Then you integrate in value analysis. You're using the total cost of ownership modeling. You figure out what your data source of truths are going to all be, not just on the supply side, but on the outcome side and the cost per case side and all of these things. And then you start to standardize, not just formulary, but also clinical practice. Because if you're thinking about clinical pathways and when a patient moves and when they're admitted and at what point in time they get X pharmaceutical and all these things that happen within clinical pathway, you start to standardize that across your entire health system. Then you start to reduce variation in supplies, in equipment, and clinical practice. And then you start to optimize your workflows. So just think about that for a minute. Incredible. It helps with education. It helps with all the other clinicians getting on board, not just the physicians. This is a leadership shift. This is a cultural shift. Has to be driven by the C-suite. So thinking about this blueprint framework, right? Having governance, Figuring out where data and your analytics are going to sit. Who's going to pull the data? Who's going to model the data? Where is the data? How can you pull all the data together and then start modeling it all together, right? As a package. You've got your clinical integration. Strategic sourcing, right? Has to be a part of that along with your clinical value analysis team and supply chain. But bringing strategic sourcing and contracting team in to help connect with the vendors, help hold vendors accountable, help understand why something is one way. And then having that total cost of ownership alignment. Crazy, mind-blowing. All right, so I keep thinking about strategic supply chain. And I always am telling all of you suppliers out there, be strategic, stop being so transactional. It is no longer about the price at the pump. How can you as a supplier lean into value-based care? Everyone should be thinking strategically here moving forward. So if you've got these service line, clinical operational service lines, councils or teams or whatever you guys want to call them, outcomes are linked. You have outcomes linked decision making happening. No longer are people feeling, well, I can't make that decision in value analysis. I think only a hospital president can make a decision or a C-suite member can make a decision. No, everything's now based on data. You've got supply chain data, you've got outcomes data, you've got all of your readmissions and quality and all those things data and your infection rates, and everything is outcomes linked decision making, data driven decision making, right? Standardization pathways within your clinical pathway, within clinical practice, within your supply, within your equipment. We are all using this as our supply, which then means this is our clinical practice. This is our clinical pathway. And then thinking about variation dashboards, having stoplight, red, yellow, green, where are you having issues? And maybe it is in supply chain, and that's okay. But then tying that to vendor scorecards and vendor performance and sharing in a risk model strategically with your vendors where outcomes data is poor because of you have done root cause analysis and it's because of a supply. Then figuring out with your vendor how to be strategic and how you share in that. The cost of staying reactive, you have higher length of stay. You're buying the cheap crap, you're going to have higher length of stay. Low outcomes, right? Low patient outcomes, missed reimbursement. I'm talking about these penalties that are coming our way. CMS is really understanding what this should look like. Why would an insurance company or CMS reimburse when you have to keep readmitting somebody? Whose fault is that? Who's causing that? Why would CMS, Medicare, Medicaid have to reimburse for that? It's not their fault. Why would they pay for that? Burnout. Staff is burnt out. We're not just talking about clinicians. We're talking about supply chain, finance. Everyone in the decision-making model is burnt out. We have a lot of chaos. No one understands who is the decision maker here. And a lot of wasted time. I don't know how many times we've made a decision in value analysis and we've had to unroll it because we forgot someone in the decision-making process. So you guys always know I do massive action checklist starting tomorrow. Inside that checklist, it's about a page and a half of things to do where you guys can go start implementing tomorrow. I want you guys to have impact tomorrow. I want you to pilot total cost of ownership on a product category or one product or a piece of equipment. Think about how you're going to launch standardization across your health system or across your hospital for one thing. But where are you going to get your data? Where are you going to not just get your supply chain data, but your outcomes data and your costing data, right? So you're going to have to bring in finance. You're going to have to bring in quality. You're going to have to bring in population health. You're going to have to bring in all of the leaders who control that data. And maybe start a governance meeting. Do you have a clinical operational service line that is functioning well? Maybe it's cardiovascular, maybe it's imaging, maybe it is neuro, right? Maybe it's working really well and they're doing great things there. How could you bring in some governance and say, how could value analysis fit into this? Think about a variation heat map of some sort. Where are we having variation, not only in supply, right, or in our formulary, but also in our clinical practice? Who are the outliers? Maybe it's a physician, maybe it's a clinician, right? And track the outcomes of that. That is what I'm going to be sending you guys as your massive action checklist for today. Some hot final thoughts. This is your time to step up. I actually have a blueprint on how to get you there. If you're interested, it is time to move forward with the blueprint of assessing your supply chain and how this is all set up. But also, you guys really should make sure that as a supply chain team, you are pushing your C-suite into this, because this is where you're going to start saving money. This is cost containment. Total cost of ownership is cost containment, not trying to save a couple pennies on a contract. That is not cost containment. This is where you guys step up and you become strategic leaders within your health system. So, hey, let me know if you're not getting my emails right away, because I always send at the end of this, by tomorrow, you'll get your replay, you'll get your massive action checklist, you'll get your PowerPoint. I want to make sure you get them. If you don't, contact us at customer service at healthcaresupplychainhub.com. If you're watching this replay on YouTube, make sure you're subscribing, make sure that you're following our team. We're doing awesome things out there in supply chain, and I'm so glad that you guys are with us. It was very, very good to see you all. And I hope you guys have a great rest of your day. Thanks, team. Bye.